Passive physiological intervertebral movements, or also known as PIVMs, can be used to assess range of movement at each vertebral segmental level. You can assess the range of movement at each vertebral level, comparing with the level above and below. However, it should be remembered that it is normal for different regions of the spine to have varying amounts of mobility. As the anatomy and biomechanics of the upper and mid and lower cervical spine are different, I'm going to show you the PIVMs for the mid and lower cervical spine in a different position from the PIVMs that we will use in the upper cervical spine. So starting off with the PIVMs that can be used in the mid to lower cervical spine. The patient is supine lying with the head over the edge of the couch. The crown of the head rests in the physiotherapist's abdomen, using slight pressure against the crown of the head to stabilize the head position. Two hands are placed round the occiput, with the index finger palpating the interlaminar space of C2 and C3. The thumbs are placed anteriorly over the angle of the mandible. The therapist is standing with the feet comfortably apart, and the extension movement is brought about by flexing the knees, moving to a semi-squat position, like this. You assess the range of movement at each segmental level, and then move on to the next level below. What the therapist feels as you perform the movement is that the interlaminar space decreases, so you get approximation of the laminar structures on the posterior aspect of the neck. Prior to performing this technique, you'll have asked the patient to warn you of any symptom reproduction. In the presence of hypomobility, the therapist could appreciate less movement occurring at the involved segmental level. In a similar position, you can also assess cervical flexion. Can I ask you just to move down the bed just 1 minute? For this technique, the bed needs to be slightly lower. And if you can move back up again. And a little bit further. A little bit further still. That's grand. Same as before, the crown of the patient's head rests against the physiotherapist's abdomen, and you apply slight pressure to the crown of the head to support it, but not causing excessive compression of the cervical spine tissues. You're also going to support the head using your hands posteriorly, but keeping the index finger free to palpate the interlaminar space on either side. The thumbs come anteriorly, so they are positioned over the angle of the mandible on either side. As before, you've got your feet comfortably apart, but this time you're going to start off with your knees flexed. The passive flexion movement is brought about in the spine by extending your knees as so. As before, you palpate each segmental level, starting from C2, working down towards C7. So I'm going to start here and palpate the movement at C2, 3 level as I flex the spine. And then moving down to the relevant vertebral segment levels below. What the therapist should feel, as you bring about the flexion movement, there is an increase in the interlaminar space, so the laminar structures move apart. In the presence of hypomobility, this movement may be decreased. We can also then assess rotation and side flexion. Can I ask you to slide down the bed again? And slide up towards me. For side flexion, it's a similar position as before for the hands. Hands on the posterior aspect of the occiput, index finger free, so it's palpating interlaminar space, thumbs coming anteriorly, so they're over the angle of the mandible. This time the therapist is in a stride standing position, and she can sway her pelvis to the side to bring about the side flexion movement. What the therapist will appreciate as she performs the movement, with side flexion to the left, you get an approximation of the laminar structures on that side. Whereas on the right side, the opposite side to the movement, you get an opening of the interlaminar space, or an increased interlaminar space. In the presence of hypo or hypermobility, these movements may be altered. You assess the range of movement on one side and then obviously compare it with the other side. You can also use PIVMs to assess cervical rotation. You have a similar hand position to before. Your hands around the occiput, the index finger is free, palpating the interlaminar space on either side. The thumbs come anteriorly, so they're over the angle of the mandible. And this time, you're using your hands to impart the rotation movement passively to the cervical spine, like so. And you might need to remind the patient to relax their neck, as often when you're doing this procedure, the patient can tense up, and that usually means that you need to give the patient some extra support to help them to relax their neck muscles. As with cervical side flexion, with rotation to the left, you should feel an approximation of the laminar structures on the left side, on the posterior aspect of the vertebra, and you will feel an opening or moving apart of the laminar structures on the right side, on the side away from movement. In the presence of abnormalities such as hypo or hypermobility, these movements can be altered. You can also use PIVMs to assess the upper cervical spine. This can be done in a similar position, but you have the patient positioned slightly lower on the bed. Can I ask you to move back down the bed? Sorry, back up towards me, but sorry. The choice of PIVMs that you perform during your assessment will depend on your findings from earlier in the clinical examination. For example, from your active range of movement findings. You can also assess the range of movement in the upper cervical spine using passive physiological intervertebral movements. For this position, similar to before, the patient is supine lying. However, this time, only the tip of their head is over the edge of the bed. The crown of the head is supported using my abdomen with very slight pressure as before. My fingers posteriorly are supporting the occiput, and my index fingers are palpating the lateral masses of C1. Anteriorly, my thumbs are on the anterior inferior aspect of the mastoid process. As in the upper cervical spine, i.e. the occiput and C1 and C1, C2 levels, the action of flexion extension is a nodding action. This is the movement we will use to assess the range of movement at these vertebral levels. We can perform the flexion extension as an arc of movement through 20 degrees. That's assess the occiput C1 level movement,